When Malcolm Reed walked into the ER, clutching his chest and struggling to breathe, sweat poured down his face. Classic signs of a heart attack. But triage nurse Linda Patterson took one look at his black face and made up her mind. Another faker, probably pretending to get pain meds. "Please," Malcolm gasped. "My chest hurts badly. My father died of a heart attack at 50. Linda's tone was cold. "Everyone has a story like that. I've evaluated you. You're not an emergency. Have a seat." When Malcolm tried to insist, Linda grew irritated. "I've moved you to the bottom of the list. Stop the act. There are real emergencies here." Malcolm sat quietly, pain worsening, breath fading, for 4 long hours. Then, as he clutched his chest and collapsed forward in his chair, the security camera caught everything. The alarm blared. Doctors rushed in. Why was this man waiting 4 hours? "He's having a heart attack," one shouted. Linda's face, shock, fear, then denial, was all recorded. But what she didn't know was that Malcolm wasn't just any patient. He was a state health inspector with the power to revoke the hospital's license. And her drug seeker note would end not just his heart attack, but her career. Before the story begins, drop a comment. Which city are you watching from? And if you believe in justice and equality, share this story and subscribe. Because together, our voices are stronger. Malcolm Reed woke that March morning in Atlanta at 5:30 a.m., as he had for the past 20 years. At 48, he was the chief inspector for the Georgia State Health Department, the authority responsible for licensing every hospital and healthcare facility in the state. His job was both powerful and crucial, conducting inspections, investigating complaints, and deciding whether facilities met standards necessary to operate. Over 3 years, he'd inspected 47 hospitals and suspended licenses for 12 due to quality failures. But that morning, as Malcolm poured his coffee, he felt pressure in his chest. Subtle at first, then growing. A tightness that made breathing effortful. His left arm began to tingle. The pressure became crushing. Cold sweat broke across his forehead. Malcolm had reviewed enough cardiac mortality cases to recognize the signs. This was a heart attack. He drove himself to Piedmont Rivers Medical Center, a large hospital in northwest Atlanta that he'd inspected 8 months earlier, finding their emergency department well-managed. Ironically, he'd been impressed by their protocols for rapid chest pain assessment. But today Malcolm wasn't an inspector. He was a patient, frightened, in pain, hoping for the professional medical care he'd spent his career ensuring others received. The automatic doors slid open and Malcolm entered the emergency department, one hand pressed against his chest. He approached the triage desk where Linda Patterson, a white woman in her late 40s, sat reviewing paperwork. Linda looked up, her trained eye assessing the patient. What she saw didn't match her mental image of a cardiac emergency. A black man in casual clothes, jeans, and polo shirt, fitting the profile she developed over 12 years for what she called drug seekers. "I need help," Malcolm said, his voice strained. "I'm having severe chest pain. It started about 40 minutes ago. My left arm is tingling. I'm having trouble breathing." Linda's expression remained neutral, but her mind had already categorized him. "Have a seat, and I'll get your information." "Name?" "Malcolm Reed." "But please, I think this is serious. My father died of a heart attack at 50. I'm 48, and these symptoms." "Everyone thinks their symptoms are serious, Mr. Reed," Linda interrupted dismissively. "I need your information first." "Insurance card." Malcolm fumbled for his wallet, hands trembling. He handed over his cards. Linda barely glanced before beginning routine questions. "What brings you in?" "Chest pain. Severe pressure, like something's crushing my chest. Pain radiating to my left arm. Shortness of breath. Cold sweats." Linda typed without looking up. "On a scale of 1 to 10? 8. Maybe 9. Are you taking any medications?" "No. No medications at all." Linda looked up meaningfully. "Nothing for pain management?" Malcolm understood the implication. "No. I don't take pain medications. I'm not seeking drugs. I'm having cardiac symptoms." "I didn't say you were seeking drugs," Linda replied, though her tone suggested otherwise. Have you used any recreational substances in the last 24 hours? No, Malcolm said firmly. I think I'm having a heart attack. Can someone examine me? Take vital signs? Do an EKG? Linda sighed. Mr. Reed, I've been doing this 12 years. I can tell genuine emergencies from exaggerated symptoms. Your color is fine. You're not diaphoretic beyond anxiety, and you walked in under your own power. I am diaphoretic, Malcolm protested, wiping sweat. I'm having trouble breathing. Something is seriously wrong. Everyone who comes through those doors thinks they're dying, Linda said, patience exhausted. If I treated every chest pain as cardiac emergency, we'd never get to actual emergencies. You'll have to wait your turn. Can you at least check my blood pressure? When it's your turn. We prioritize based on medical necessity. Right now, you're stable enough to wait. Malcolm wanted to argue, but crushing chest pain made thinking difficult. He took his cards back and walked slowly to the waiting area, each step requiring effort. He didn't pull out his work ID, the credential identifying him as chief inspector. He'd learned being black meant credentials often didn't matter until too late. And some part of him wanted to see how this hospital actually treated patients when they didn't know who was watching. He sat in an uncomfortable plastic chair. The chest pressure intensified. His left arm went from tingling to numb. Cold sweat continued, shirt clinging to his back. After 30 minutes, Malcolm approached the desk again. Linda appeared immediately. Mr. Reed, you need to wait your turn. It's getting worse. The pain is worse. I really think. Sir, if you continue being disruptive, we'll ask you to leave. You've been triaged. Making demands doesn't change your priority. Malcolm returned to his seat, fear mixing with familiar anger, being dismissed, having pain doubted, treated as suspect rather than suffering. He'd read the studies about black patients' pain being systematically undertreated, symptoms dismissed. He'd spent his career trying to fix these disparities. Now he was experiencing them firsthand. Another hour passed. Malcolm watched others arrive and be taken back. White teenager with sports injury, elderly white man with back pain, white woman with migraine. Each called before him, despite arriving after. At 2 hours, Malcolm could barely breathe. Pain spread across his chest, jaw ached, nausea set in. He approached the desk, barely able to stand. Please, he gasped. Something is very wrong. I need help now. Linda looked at him with undisguised irritation. Mr. Reed, I'm going to be direct. We see patients like you every day claiming cardiac symptoms because they know it gets them seen faster. Usually, they're looking for pain medication. You're not presenting with genuine cardiac distress. You're presenting with anxiety and drug-seeking behavior. Sit down and wait, or try another emergency room. I'm not seeking drugs. I'm having a heart attack. No, you're not, Linda said flatly. I've seen hundreds of actual heart attacks. You're not having one. Now sit down before I call security. Malcolm stumbled back, no longer having strength to argue. The room spun. Pain was excruciating, vision narrowing. At 3.5 hours, Malcolm slumped forward, clutching his chest, unable to remain upright. An elderly woman nearby screamed for help. A security guard rushed over. Get a doctor. Now, Dr. Sarah Chun, the attending physician, came running. Nurses rushed with wheelchair and equipment. Malcolm was surrounded by medical professionals who finally recognized what should have been caught 4 hours ago. Why has this patient been sitting here 4 hours? Dr. Chin demanded. He's clearly in cardiac distress. He said chest pain, but was stable, ambulatory, Linda stammered. He's having an MI. Dr. Chin snapped. Hook him up. Get an EKG. Page cardiology now. Within minutes, Malcolm was on a gurney, monitors attached, EKG running. The screen showed massive ST segment elevation, significant heart attack. Jesus, Dr. Chin whispered. This is massive. How long? 4 hours, the security guard answered. He looked bad when he came in. Dr. Chun turned to Linda, fury evident. You kept a STEMI patient waiting 4 hours. I didn't. He didn't present as. Get out. We'll deal with you later. Right now I have to save whatever cardiac muscle hasn't died because of your negligence. As the team worked, Dr. Chin noticed Malcolm's wallet. She picked it up and froze at the ID card. Georgia State Health Department, Chief Inspector Malcolm Reed. The man who'd waited 4 hours during a massive heart attack was the person with authority to shut down their hospital. Malcolm was rushed to the cardiac catheterization lab. The damage was significant. For hours untreated had destroyed substantial heart muscle. But doctors saved his life, though recovery would be long and his heart permanently weakened. The investigation revealed a horrific pattern. Over 3 years, Linda had flagged 47 patients as suspected drug-seeking. Of those, 43 were Black or Latino. Of white patients with similar symptoms, only 2 of 178 were flagged. 9 Black patients Linda dismissed required emergency interventions. 2 others suffered heart attacks while waiting. Elderly Dorothy Jenkins died from pulmonary embolism after Linda dismissed her shortness of breath as anxiety. Young Terrence Washington suffered permanent kidney damage after Linda delayed treatment. The pattern was undeniable and documented in hospital records. Linda had systematically provided inferior care to Black patients based on assumptions their pain wasn't real. Malcolm's family filed complaints. Federal investigation began. Linda was terminated and her nursing license permanently revoked. The hospital paid $2.3 million settlement and implemented comprehensive reforms. But impact went beyond one hospital. Malcolm's case became national news, sparking conversations about racial bias in emergency medicine. Medical schools incorporated his case into curricula. New guidelines addressed implicit bias in triage. Malcolm returned to work 6 months later, implementing statewide regulations requiring hospitals to track and report emergency wait times and treatment delays by patient race. Hospitals showing disparities would face mandatory review. Linda's case became training material nationwide. The recordings of Malcolm's pleas and Linda's dismissals became evidence in federal programs about deadly consequences of racial assumptions. 3 years later, Georgia hospitals had significantly reduced racial disparities in emergency care. Malcolm's near death forced a reckoning that regulations alone never achieved. At a medical conference, a young Black medical student approached Malcolm. "Dr. Reed, because of your experience, because you spoke out, I'm going into emergency medicine. I'm going to be the doctor who sees patients like us and believes them." Malcolm's heart would never fully recover from those 4 hours. But if his pain prevented even one other person from suffering the same way, it had meaning beyond tragedy. Linda never worked in healthcare again, but her legacy persisted in every hospital now tracking disparities, every medical student learning about bias through Malcolm's case, every protocol requiring documentation of triage decisions. Sometimes justice comes too late to prevent all harm. But when it comes with power to create systemic change, it prevents countless future harms. Malcolm's heart bore permanent scars from Linda's discrimination, but his voice helped heal a fractured system, one policy, one hospital, one medical student at a time.